Introduce myself, I'm Loic Menzies. I'm the chair for this afternoon. My role is primarily as Chief Research Officer at the Centre for Education Systems, which is a new international research institute comparing education policy across 14 different countries. We've recently been generously given funding from a Nuffield Foundation to do some work which closely overlaps with what we'll be discussing today, partnering with UCL and King's College London to look at special educational needs and disability policy across a basket of 14 countries. So this is an area I'm very much interested in and have also done a lot of work on in the Institute for Public Policy Research as well in terms of shaping policy in this area. And I've been asked to play the role of an enhanced chair today. I'm not quite sure what that is, but I'm sure we'll work it out as we go along. But part of that is to sort of give us a bit of a framing and sense of where we are on this. So I think I'm probably not alone in recognising that we're at a very critical moment in the future of policy in some of the areas we're going to be discussing today. To just give a few of those headline stats that I'm sure people are well aware of, we know that in 2022, 1 in 4 17 to 19-year-olds were being identified as having a probable mental health condition. We know that there's been a tripling in A&E admissions for psychiatric conditions amongst under 18s from 2010 to 2018. And in the area of special educational needs, we're expecting some significant action from government soon. We know that there's been a 140% rise in the number of EHCPs since 2015. So there's a lot going on here and lots of action in terms of policy here. But a lot of that obviously is grappling for answers, and I don't think anyone's landed on the right answers yet. But we know that quite early on, under the new government, there was the introduction of the Schools and Wellbeing Bill, which we know includes all sorts of provisions for enhanced multi-agency working, for child protection, collaboration and information sharing. We know that we're expecting a Send and Schools white paper in the autumn, and that there are provisions in the spending review for that of £170 million for a transition fund there. And then there's also all sorts of other actions there which Charlotte's going to be talking about a bit around mental health support teams in schools, the neurodiversity task and finish group that Duncan's involved in, but important overlaps here with other policy areas. So this really falls in that space of an area that crosses over departmental boundaries, which is always so difficult for government policy making. So no shortage of big questions for us to look at today, but we've got an amazing panel to help us think through some of those questions and to bring some of the evidence that's needed to help us find a way through this. So I'm going to ask them first to each introduce themselves, and then we'll take input from each of them for about 10 minutes each before we move into a nice chunk of time for discussion. So Tamsin, do you want to introduce yourself first?
Yes, hello everyone. My name is Tamsin Ford. I'm a child and adolescent psychiatrist by background and head of Department of Psychiatry at the University of Cambridge. Nice to see you all.
Thank you. Charlotte?
Hi everyone, Charlotte Keane-Holland. So I am Deputy Director for Mental Health Strategy and Policy Delivery in the Department of Health and Social Care, which covers a multitude of things, but essentially responsible for the kind of key manifesto commitments on mental health, but then also lots of the kind of cross-government, cross-missions work, which obviously has mental health underpinning and should have mental health underpinning all of that.
Thank you. And Duncan?
Hi, I'm Duncan Astle. I'm Professor of Neuroinformatics, also at Psychiatry at the University of Cambridge, and I primarily study brain development in childhood.
Fantastic, thank you. Okay, well, we're going to ask, we're down to have Tamsin first, but we don't know whether the slides are going to be Duncan first. So I think we're going to have Duncan first instead.
Okay.
Follow
Great.
the tech.
And as if by magic, do I need to advance the slide? No. I think it's coming.
It's just to build up. There we go.
There we go, just to create a sense of suspense. Okay. So I've titled this talk 6 Things That Are Really Worth Knowing About Human Brain Development. So I could speak for hours about all the exciting work we're doing, but I'm just going to try and focus on stuff that I think is really relevant for the discussion that we're about to have. So just to set the scene a little bit, I'm sure everybody in this room knows that neurodevelopmental and child psychiatric conditions are really pretty common. I've put 15% there. Of course, who knows if that's the right figure, right? Because it depends on where you live, depends how you define it, but I think a ballpark figure of 10 to 15% is probably plausible. And these neurodevelopmental conditions can involve a wide range of different impactful cognitive and behavioral characteristics, often with lifelong consequences. And the really tricky thing is that the underlying causes are largely unknown. And just to give you a little idea of what we do, we study the role that the brain might play in the onset and the maintenance of those kinds of difficulties. And we use lots of different techniques that allow us to work across the different levels that might be relevant for understanding those difficulties. We try and map differences between kids. We work with engineers to try and build models. And then we've got a side hustle on trying to broaden access to education, informed by the research that we do. But enough of that. Let me tell you about my 6 important things that I think are really worth knowing. And the first one is that human brain development is long, like really long, or rather slow. And so if you start off by just thinking about how big the human brain is, so these are some brains of us, the humans, and our closest relatives. They're not to scale, I should say, but you can see in the numbers the overall volume of the brain. And so you can see how vastly big the human brain is relative to other species. It's special in other ways too, right? It's really, really dense. So if you plot up the y-axis, the overall mass of the cortex, so the amount of cortex, and then the number of neurons along the x-axis, you can see that, broadly speaking, those two things are directly related. You can see that primates primarily kind of bump that trend, and humans are a real outlier. So our brains are way more dense than you would expect them to be relative to the rest of the animal kingdom. And the secret to how this is achieved is really, really slow development. So this is a project done by a colleague of ours called Richard Bethlehem. Very complicated lines, but it involves basically using MRI scans from over 100,000 people from before birth all the way up to 100 years of age. And the 2 lines that are really worth looking at is the kind of peachy orange line. So you can see it rises up to form a peak at about 6 years of age, and then slowly decline. So that's grey matter volume. That's the outer 6 millimeters of your brain, right? And so it peaks at about 6 years of age, and then you get what's called synaptic pruning. That's a good thing, and so you gradually get a refinement of the synapses over time. The other line that's really, really important to look at is the kind of light blue cyan line, and you see it rising really steadily and not peaking until you're 30 years old. That's white matter. That's the kind of myelinated fibers that connect different parts of your brain. And so the human brain is unusually large, it's unusually computationally efficient, it's extremely slow in its development, and because of that, the slowness allows for us to maximize various different properties. A big feature of our development is that a disproportionate amount of our time is spent in the ex-uterine environment, so we spend a lot of our development outside in the real world. A giraffe drops out, within 5 minutes it's up and running around, it's pretty well developed. A human being arrives, useless for many years. And you might think this is an extraordinary design flaw, but it is actually the secret of our success as a species, because this incredibly slow developmental process has allowed us to develop this enormous intracranial volume. So we have this incredible computational device between our ears. It's incredibly efficient in its organization because it takes so long to refine and build. And it means that we are maximally adaptive to the environments that we grow up in, for better or worse. Okay, so it's second thing. It's long, but it's massively variable, right? So a natural consequence of the process being so long and outside in the real world means that it's hugely probabilistic. That means that you cannot predict the end state from the beginning. Even in identical twins, they diverge in many ways across development. This results in a massive amount of heterogeneity in phenotype. And again, you might think, wow, that seems like a real design flaw, but it's not. It is part of the secret of our success as a species. So that variability across individuals, we are a lot more different from each other than giraffes are different from each other, means that as a species, we're much more likely to be able to adapt and survive through our evolutionary past. But it can be a massive challenge for things like education systems. So in a lot of our work, we spend a lot of time modeling brains and essentially exploring how you can create this kind of variability and showing why it's so beneficial for a species. Put simply, there are large amounts of variability in our phenotype, and for instance, in our cognitive abilities, and that is a very natural part of being human. And in my view, it's not something that we're going to fix. And so we do a lot of work on school inclusion. So what does school need to look like given this massive amount of variability that exists across individuals? Okay, so thing 2, it's very long and massively variable. Thing 3 is all the common neurodevelopmental mental health conditions have their onset during this elongated developmental window. So we've got the top part is the graph I've already shown you. Underneath now in these blue boxes, you can see the time windows in development when you're most likely to receive a particular diagnosis of, say, autism, ADHD, anxiety disorders, schizophrenia, depression and bipolar, and then right at the end of life, Alzheimer's. So what you can crucially see is that, especially for things like autism, ADHD, and anxiety, they typically have their onset in kind of mid to late childhood or into adolescence. So most common conditions have their onset in late primary school years. Mood disorders tend to happen slightly later, although in my experience it's creeping slightly earlier. Severe mental illness, as it's sometimes called, tends to happen slightly later in life, but the vast majority of these difficulties will emerge during this developmental period. I'm looking at Tamsin and she's nodding her head. Okay. So what causes them? We don't know. So if you scan kids' brains, adolescents' brains, and young adults' brains, those reddish patches are called association cortex. And that's where the majority of the changes are happening from childhood to adolescence to young adults. If I overlay that with the brain areas that seem to be most associated with differences in your environment, it's the same or very similar brain areas. If I overlay that with the parts of the brain that are most expanded in a human relative to a monkey, then you'll see that it's very, very similar brain areas. And if I were to scan, 100 kids with ADHD and 100 kids without ADHD and compare their brains, if I found any differences, it would probably be somewhere in those red patches. The problem is that when my colleague down the road does the same study, which takes 100 more kids with ADHD, compares them to the controls, they don't replicate the effect, right? If they find an effect at all, it'll probably be somewhere else. And so this is the recurring theme. There's a really nice review by Sam Cortese down in Southampton. They reviewed 780 studies looking for that biomarker, the thing that predicts a neurodevelopmental condition. And there are none. There are none that meet our kind of standard criteria, sort of 80% sensitivity and specificity. I couldn't help but show you the tweet that comes straight after it, which is someone just said, we're hoping to fix that for Tourette's, waiting for our review. And it's, as a field, we keep coming back to this hunt for the biomarker. Like the 781st study is going to be the one that really nails it. So association cortex, often late to mature. They're also the most sensitive to the environment. They distinguish us from our ancestors, and most correlates can be found in them, but we struggle to replicate. And why is that? Because our brains reflect a complex adaptation to our environment, our own behavior, and our genetic backgrounds. In other words, there are lots of ways of being anxious. Fifth thing, almost done. If you qualify for one diagnosis, you'll qualify for loads, or at least multiple. Let's not say loads. So having a learning difficulty, for instance, is a major risk factor for having a mental health condition later in life. Having ADHD also makes you much more likely to receive an autism diagnosis. And why is that? Because the natural differences between human beings don't fall neatly into categories with distinct causes and symptoms. So this is something that we've studied a lot. And in fact, it turns out that the formal diagnosis a child has is usually a pretty poor predictor of their profile and set of needs. And of course, that's a real challenge when you're trying to configure systems of support around individuals on the basis of a diagnostic label. And the final thing is that there are strong risk factors for poor mental health and neurodevelopmental conditions, but they're really, in my experience, pretty non-specific. So if I correlate the genetics of different conditions, you'll notice there's lots of blue, and that's because they're all really well correlated. Because it turns out that the genes for autism aren't really the genes for autism, they're the genes for something developmental that might also relate to you having an anxiety condition or something else. If you do what's called a structural equation model, where you try and chunk up the variance, you can just about make out different types of disorder. But if you look at the top arrows in the kind of what we call the latent space, you can see that they're all pretty well correlated with each other. So the genes are a risk factor, but they don't tend to distinguish disorders. And we've also done a lot of work on early life adversity. Again, it's a big risk factor, but it doesn't tend to be specific. Okay, so quick summary. Human brain, very big, slow to develop, but very powerful. The developmental time frame means that we're very variable across individuals, and that variability is an important feature rather than a bug. Most developmental conditions and mental health conditions have their onset during development. We haven't got any good biomarkers. The diagnostic systems don't do a great job. And there are strong risk factors. And that is me done.
Wow. Thank you, Duncan. I certainly learned a lot there. And I guess in the spirit of today's conference, I'm going to go into leaving with the science and now some policy. From Charlotte, please.
Thank you. I think I've got some slides there. My slides are nothing like Duncan's, I'm afraid. I'm sure many of you would have seen government slides before, so I would love to be more creative, but here we are. Really helpful reflections there from Duncan, and I think some really interesting points that'd be good to get stuck into in the discussion, because I'll actually start with this slide, because I think a lot of the things we're talking about here lend themselves to the direction of travel that we need to kind of move towards in terms of policy making. I will speak to the mental health perspective, but obviously colleagues here will very well plugged into kind of neurodiversity side of policy making at the moment. But one of the things that we're really keen to do is make sure we move away from the biomedical model, which has led a lot of healthcare provision for a long time, and think about, as Duncan was saying, what a kind of needs-based model would actually look like. So whenever you come back to these things, I guess in policy making terms, it's always early intervention, which we know to be key, and prevention where you can do it, and actually making sure that what we get is the right support to the right people at the right time in whatever that means and whatever form that takes. And I think particularly for policy making, and it's obviously a very difficult field given the things that Duncan's just outlined in terms of causality being very difficult, but I suppose this bottom part of the triangle is really what we increasingly want to get into, which is what are those kinds of basic conditions that you can create for both a mentally healthy society. The same goes for thinking about kind of support for those with neurodivergent conditions. Actually, what are the things in that bottom bit of the pyramid which we can do to collectively address some of those challenges? There's lots that we're doing, across government at the moment in terms of initiatives at the top of that triangle. We do, obviously kind of government's commitments around how we reduce waiting times, what we need to do in terms of sort of ongoing mental health services support are critical, and there's a lot going on there. But I think particularly for today, thinking about those bottom level conditions and where some of the kind of interventions that we've got, like mental health support teams in schools, can really help to bring together some of the considerations about what will actually help kind of particularly young people to get the support that they need when they need it. These are some of the sort of interventions that we have at the moment, and as we said at the beginning, this is obviously hugely cross-cutting, and mission-led government is helpful, and I think a move in the right direction for making sure that some of these types of issues are discussed in the right forums and in the round. So you can see lots of departments named on here, which is actually, I think, pretty unique for a government slide. So I think does speak to the kind of helpful trajectory that the missions have set us on. And actually, there's lots, we can touch on some of these in the discussion, but lots that we're doing with DFE and that colleagues on this panel are involved with to make sure that we are kind of joined up as a fully cross-government approach. We've got things like DCMS's National Youth Strategy, but within that, there's obviously a lot of focus on getting the right support for young people and thinking about what needs to happen between the ages of kind of 0 to 6, 6 to 12, and thinking about the right kind of categories of thinking about some of that. And then obviously with colleagues in NHS England, there's a lot of work as well going on to try to frame some of this. But I think lots of these things will kind of come to fruition at a similar time. So it is really now the time to be thinking about what do we want to do with that in the round, and actually how do we create the right narrative around some of this, as well as the specific policy interventions, because this is something that that is inherently human, and actually I think one of the things we're trying to do, and will be really important post the kind of 10-year plan in the next couple of weeks, is think about what narrative do we want to set on this agenda for the next 3 years, 5 years, 10 years, because it's just such a critical one. And just speaking briefly to the 10-year plan, which some of you may or may not know is due to be unleashed soon to the world. And I won't kind of comment, I can't comment on the specifics, but just the kind of general strategic direction. We have the sort of 3 key buckets of the 10-year plan, kind of predicated around the 3 big shifts that we need to make. So moving to kind of from analogue to digital, so in a mental health context, thinking about how, again, particularly for young people, we can think about addressing some of the challenges around long waiting lists, the need to intervene sooner, how can we unlock digital as a way to actually get people that earlier support when they need it and avoid the waiting lists being the solution, and equally the same for diagnosis. Shifting from sickness to prevention, so again coming back to that bottom layer of the triangle, how do we do much more in that space, both for NHS services, but also using the missions and the momentum of that to get the kind of wider socioeconomic determinants of poor mental health into the equation when we're thinking about healthcare and support. And then hospital to community is the kind of 3rd big shift, so making sure that we are doing everything we can to bring care into the community. And again, for young people, that's things like commitment to Young Futures hubs, so in every community, having a space where there's kind of no wrong front door for people to come and seek support. And again, the narrative here will be really critical, because we want to make sure that for all of those young people, that no wrong front door does mean support for whatever kind of either crisis they are turning up for or whatever kind of support they are seeking, be that kind of greater understanding of their own needs or what they're going through in terms of their development. So lots of kind of interventions that are very much squarely in this space, and I think we're at a really key turning point in trying to make sure that we really get the understanding right in what is a very complex kind of sphere, but actually in policy terms, really important that we actually get the drivers acknowledged, and whilst we can't find causality, make sure that we don't use that as a kind of reason not to address it as fully as we can.
Great, thank you. I think definitely already some themes starting to come out across both presentations, particularly that actually resonate quite a lot with some of the data we're starting to bring together internationally, particularly in terms of England and its quite outlier status in terms of its dependence on diagnosis in order to find support. So that's something that's unusual in England compared to many other countries that we're benchmarking the system against in the research that I've been involved in. So thank you for that. Okay,
Okay, so as if by magic, some more slides. It's quite unnerving seeing the mouse disappearing. So I'm very gratified Duncan thinks that I know the answer. People think that prevalence of mental health conditions or neurodevelopmental conditions is kind of a magic number that we just have to consider. We just have to investigate and we'll find what the prevalence is. It's all dependent on definitions, and as Duncan has articulately said, our classification systems, and I would also argue the way we try and measure difficulties and strengths in children, do not carve nature at the joints very well. However, they are the best that we have. So my job is to talk to you a little bit about the mental health of children and young people, and I'm going to fall back on our official government statistics. And we have this amazing survey series, and we should be really proud of these. These are some of the biggest and most rigorous mental health surveys that have been done worldwide, because every single child had a multi-informant standardised diagnostic assessment. And what that means is every single parent and every single young person, and if the family agreed, a teacher as well, were approached and had the same detailed assessment. There were script rules that narrowed things down, so we didn't plug away at asking people questions when there was no point, but it was very, very thorough. And then a small team of clinical raters put all those data from all those informants together to make a decision, as we would in the clinic, does this child need help? Because that was the exam question that the Department of Health asked us. How many children out there warrant a clinical intervention? So there is this, it actually spans my academic career. So I was a clinical rater and I helped develop the diagnostic measure in 1998. And then there was another one in 2003. Then there was a big long gap where we forgot about children and then we remembered them again in 2017. And we were due to go back in 2020 and something happened around about then, didn't it? So we sort of had to pivot a bit, but we actually went back. This was not designed really to be a longitudinal study other than one follow-up just to check in. But we went back every year until 2023. So the results of the 2017 survey, mainly that was conducted because there was such a drumbeat about the deteriorating mental health of children and young people, with headlines about tsunamis and catastrophic levels of distress. And I use the word distress advisedly because actually when we did the survey, yes, there was an increase, and yes, it was statistically significant, but it was a matter of a couple of percentage points. In the whole population, a couple of percentage points of children amounts to a lot more children and a lot more pressure on services, but actually it wasn't the kind of catastrophe that was widespread in the media. And if you look at the graph, so we've got emotional disorders, by which I mean all types of anxiety and depression. It was the increase in emotional disorders that seems to be causing most of the increase. And interestingly, there's a parallel series of working age adults into older adults that actually has had more waves, and there will be very shortly a publication of the most recent survey of adults. And in 2014, there was this sudden blip amongst 16 to 24-year-olds, particularly young women. And in our child survey, it was particularly the older teenage girls where they seem to be doing particularly badly. But the children's survey hadn't had data on 17 to 19-year-olds until 2017. The more neurodevelopmental of the mental health or psychiatric disorders, you can see actually hasn't changed very much. That increase of slightly less than 0.5% is probably what I was alluding to in my first statement, in that there isn't a prevalence. You have a sample and you're taking a sample and you get values and they're going to dot around. If you do it properly, they will normalise around a value in the middle. But that slight increase isn't worth writing home about. So that is for ADHD, or hyperkinetic disorder, which is the more severe version, which is why the line is lower, but it's what ICD-10, which is what we're using. And it doesn't carve nature at the joints any better than DSM does, but they've moved closer over the years, but it's a slightly more severe definition. And ICD-11, I think we're more or less at parity. What did we see during COVID? So we have this problem. We have a data gap in the younger children. So we had 2 to 19 in 2017. And of course, children get older. So what I'm giving you every year is the same age groups. It's not the same children. So it's like repeated cross-sectional surveys. This is not the individual trajectories. The data is only just available for us to start looking at that, which will be very interesting to do. But on a kind of age group level, there was a deterioration between 2017 and 2020. Can't say for definite it's COVID, but that may well have been the biggest thing that happened, and that seems to be sustained. Affects both age groups, both genders, but again, as in 2017, it's the older teenage girls who are doing the worst. So I want to say a little bit about access to services. This work has been taken outside the survey reports by Tamsin Newlove Delgado, who works in Exeter, a colleague of mine. And what we have is quite a lot of unmet need in terms of those who meet the criteria for a disorder. And we're hobbled by language in relation to mental health. A lot of medical conditions, some people would argue all of them, are spectrums or normal distributions. Think of diabetes. You put a cut point on a blood sugar level and you say if you're over that, you have diabetes. But actually, if you're 1 millimole less, you're probably at increased risk. Similarly, breathing in asthma, how much you can breathe in and out. Similarly, high blood pressure, people don't even feel unwell necessarily unless their blood pressure is very high. They just have an accelerated risk of heart attacks and strokes, and therefore we treat it and we have arbitrary cut points at which we say, you have a problem. It's the same with anxiety and depression and the kind of difficulties that can arise many neurodevelopmental disorders like autism and ADHD. There are traits, there are a few of us who are really chilled out, and there are some of us who are absolute tickers and can't sit still and can't focus our concentration. The awful thing about being a child is you have to go to school, and there is this environment that perhaps is not terribly accommodating to people who aren't in that middle range. Now, to meet criteria for a disorder, you have to be impaired, and these difficulties have to have persisted. And that's what differentiates psychological distress, which may be completely normal. If you're not anxious when you're giving a presentation or going for a job interview, you probably don't care about what you're talking about, you probably don't want the job. It's a completely normal physiological feeling. However, if the prospect of giving a talk in 6 months' time has you not able to sleep, not able to eat, not able to concentrate on your work, feeling physically sick, perhaps having diarrhea, anxiety at its most severe can be very impairing. And the real problem for children is they incur a developmental impact when they're not functioning. If any of us in this room were mildly depressed for a month or two, it probably wouldn't be great for our families. It might not be brilliant for our jobs, but it's not going to leave you behind in your development from your peers. It's not going to leave gaps in what you know at school. And depending on the precise timing, the key years when depression hits is the mid-teens. Well, that's when we start doing high-stakes exams. Anyway, what you can see from this is only about a quarter of those who met criteria for a disorder, so impaired, got to a mental health service within the previous 12 months. And in fact, nearly a third hadn't seen any professionals at all. And there are inequities, so people from lower socioeconomic status measured in a number of different ways, and those from ethnic minorities were even less likely to. So that's the average. So there's some baked-in inequalities. But when we're thinking about that triangle and those lower-level services, we need to be cognizant of this, because not everybody who needs help gets to help. And I want to divert here to talk a little bit about all the stuff we're seeing in the media about overdiagnosis of particularly ADHD and autism. Somebody who remained nameless at Cambridge was heard to say, well, I can't wait till they're all neurodivergent, because then we can treat everybody the same. And there are very high levels of people coming in wanting accommodations. And I think what the population level data show us is that taking ADHD, where there is a medication that's frontline treatment, we ask people about it. In 1999, only 30% of those who met diagnostic criteria were taking methylphenidate or a similar drug that's mandated for their condition at the time. Now, they may have been offered it and not wanted it. They may have tried it and not been able to tolerate it, but it was a third, whereas the trials suggest up to 90% of them will benefit. By 2017, it was about 60%. So there has been this massive increase. But I can say all the surveys, because I personally checked it, there was no evidence of anybody in this population sample being given Ritalin who didn't have significant inattention, impulsivity, inability to sit still, and impairment. So we are not picking up in a population survey widespread overdiagnosis and widespread overtreatment. That's not to say it doesn't happen in pockets. And I think what we have seen in the work around services, and some of it's published now, with Tamsin Newlove Delgado as the lead author, is much more use of the private sector. I looked at it in my PhD at the turn of the century. And yes, I found a few cases, mostly around education and tribunals, not around health. Actually, now it's significant. It was so small I couldn't even report it without risking disclosing who people were. Now it's quite a chunk of people, and they're not necessarily getting high-quality assessments. So I would argue we're not getting overdiagnosis. We may well be getting misdiagnosis because, as Duncan said, comorbidity is the norm. If you have an intellectual impairment or a specific learning disability, you may well look very inattentive in class because you're not understanding what's going on. If you are very anxious, that can destroy your concentration. So it needs a really good level of assessment. That doesn't necessarily mean someone very highly trained or very expensive, but we need to assess thoroughly. Whereas I think what we have in some places is people going off spending a lot of money and not necessarily getting a good assessment, but maybe getting the diagnosis that they've asked for. Going to services, and this is my last slide, going to services does not necessarily mean that you get your needs met either. And I would refer everyone to the Stadia trial, which was quite a kind of bucket of water for those of us who work in relation to child mental health. The lead author is Kapil Sale. This is taken from a paper by Simon White, senior author Mina Farzel, and it's on the Oxwell survey. Now, this is absolutely enormous. How often do you see a sample size of approaching 25,000? So these are secondary school children across England, mainly around the south of England and the Midlands. And it's a network analysis of different services. And broadly speaking, the circular or the sort of oval shapes are informal services like peers, carers, not actually set up to be mental health services. The hexagons are those services that you would think of as really having a mental health role. And because it's a network analysis, it's looking at patterns of accessing services. So where there's a thick line, there's lots of children who are seeking services along those patterns. But the other really important thing is the darkness of the colour indicates how helpful those services were. So I would argue there's a clear pattern that the formal services are the least appreciated. So we are not seeing all of those who need seeing. And when we are, we're not necessarily, certainly not giving them what the youngsters think they need. And I think we need to generate better outcome data because actually just liking the service is not necessarily the point. Are we actually supporting people? The very last thing I would say is this is not a health problem on its own. The overlap with all the other sectors, particularly education, particularly the voluntary sector, is really, really important. So in the 2017 survey, if you had a mental health condition, you were 6 to 7 times more likely to have special educational needs. And the relationship is complex. So for some children, their mental health condition, autism or ADHD, will be their special educational need. In some other children, it may be that there's something in the school environment like bullying or an undetected learning problem of some kind that is the stress that's maybe making them anxious or depressed, or it may be other conditions and coincidental, but it's impairing their mental health and their ability to access education. So mental health is really is everybody's business. It's not easy to measure, but we should be proud of the data that we've got. although it shows that we need to do better at meeting young people's needs. And I'll stop there.
Fantastic. Goodness me. Very, very informative. Learned a huge amount there, and I'm really glad that we've got a good chunk of time now to have some discussion around this. All sorts of aspects of this, I think, of huge importance to policy right now. Just to name a few, in terms of what we heard about human variation and what that means for shaping public services that take that into account. Some issues around kind of increasing use of the private sector and poor access to services and people trying to fill those gaps. We've heard a bit about how this crosses between different areas of policy and the role of missions within that, particularly as that move happens towards prevention and the base of the pyramid, as you put it, Charlotte. So lots of things that got me thinking there, but it's over to you now. So if you could introduce yourself, put your hands up, and then we'll take questions in 2 questions at a time, I think. And if you could introduce yourself and say where you're from, that would be great. So hands up. Thank you. Got one question.
Thank you for those presentations. My name's Kelly Fagan-Robinson. I'm in social anthropology at Cambridge. I work with young people with special educational needs, sensory difference in care, in the alternate provision, etc., as part of my work of the breakdown between individuals and institutions in terms of their communication. But I'm also a parent of a child with autism and ADHD. And I think I have so many questions, but I'm going to stick it to just one. And that is, and it's kind of across the presentations, which I've found really exciting and interesting to think with. It's about diagnostic bottlenecks, because I'm going to use the example of my son because it's the easiest one for me to draw on. He had his CAMS diagnoses from age 4, but they didn't actually diagnose him with autism and ADHD until he was 15. And those two things went so much hand in hand, and a lot of it was down to access into the health system, into the NHS, and understanding those pathways by virtue of my work. So I'm just wondering how much socioeconomics, as a sort of broad brushstroke. So, I had this job in a profession that had access to these networks of care and access to medical support. What happens to people doing shift work with multiple care responsibilities, precarious living, within these diagnostic bottlenecks where you have potentially some CBT support, which was not that effective for him because of various other neurodiversities, but you also have this kind of, without that, you can't get access to the other things that will help to mitigate some of the anxiety and masking, etc. So that's the question. I always have this question, and I may have even asked some of you this question before, but I just thought that was the one that stuck out for me. Thank you so much.
Thank you, Kelly. Another question there?
Hello, I'm Scott McPherson. Until the beginning of the year, I worked in the UK Health Security Agent. So great presentations, thank you. Tamsin, you knocked down one of the myths that there's massive overdiagnosis going on. One of the other things that's much talked about in the media is a claim that increasing mental health problems is either due to social media and the internet or some environmental factor, whatever that might be. Is there any truth to support either of those claims? And then I was really struck by your final slide that friends, family, siblings, etc., are the most useful things. I suspect Charlotte and the DH are about to invest lots of money in medical, mental health services. Is there anything, Charlotte, coming to support friends and family to do a better job in helping people with mental health challenges?
Fantastic. Okay, so we've got Kelly on bottlenecks and the lags, and particularly barriers to access. And then we've got Scott on the question of environmental factors that might be contributing, and particularly to you, Charlotte, on that informal care question. I think Scott had some particular points for you, Tamsin, so do you want to come in?
Yes, well, the short answer about what's causing the increases is we don't know. I think there is definitely a correlation between social media use. Looked crudely, so our 2017 data, and again, we gathered more data in one of the follow-ups, maybe more than one of the follow-ups actually. There is a correlation between your mental health. So children in poorer mental health, or largely teenagers, they spend more time on social media. They feel they can't be themselves, and they're more likely to feel sort of slightly out of control of their social media use. And they're more likely to report both cyberbullying and being cyberbullied, which is interesting. It's not as simple as screen time. And it's not every study finds an association, even cross-sectionally. We lack longitudinal data, and I suspect policy will have to. There are some times where policy can't wait for the data, but I think even when you talk to young people, so I have somebody doing some work with young people in the inpatient environment with anorexia, so really, really the severest end of the scale, and over 90% of child mental health provision is in the community. So we're not inpatient heavy. So these are really severely affected people. Small and qualitative, but they themselves do not think social media took them into their condition, but they're very clear it's making it very hard for them to get out of it, which is really interesting. There are other very strong, again, mainly correlational, associations with deprivation, financial insecurity, parental mental health conditions, lots of other things that have also increased over that time. And I think coming back to Duncan's cause, the causes are many and various, and I don't think it's going to be as simple as it's just social media.
Thank you.
Should I do diagnostic bottlenecks?
Sure, yeah.
So I think one of the big challenges we face is that we've sort of constructed a system where to get support you need the diagnostic label, right? So then when parents or teachers are concerned, it's like, right, let's pop the kid on the wait list, and that could then take years to receive the diagnosis. And then in some cases, I think by the time the label arrives, it doesn't tell people something they didn't know already. And then it's not always, I mean, our own data has shown that it's not always useful for the school, and that the variability that exists within kids who have the same diagnostic label is so big that a kid coming into your class with an ADHD diagnosis doesn't immediately say, oh, these are the things they'll need. So I don't think it's controversial to say that the general feeling is that we need to gradually shift away from a system that's organised around support for kind of different diagnostic categories towards a needs-led system. And then, of course, that then begs the question, what does a good needs-based assessment look like? And it's certainly got to be more rapid. It's got to be kind of free at the point of access because of all the issues that you've raised about. You know, for instance, if I go and try and recruit a cohort of kids with an ADHD diagnosis, they're always more affluent than the general population, and that's because many of them have had to pay to get the diagnosis. So, yeah, there's the wait list is one of the big issues, and I think the diagnosis and the diagnostic label serves all sorts of different important functions, but I think one function shouldn't be you need it to get support, and I'm hoping that if we can kind of break that link, then teachers will get more information that's useful to them, and they'll get it sooner. And the number of kids needing to get on the wait list in order to get their diagnosis, to get their support, will be reduced. But that's a shift I think that's going to be hard to make, but I think that's the direction that at some point we have to move in.
Thank you. Charlotte, you might want to come in both on bottlenecks and the informal question, up to you.
Yes, so I think on the services question and point, so yeah, it's a very good one. I mean, I think to date, obviously there is a huge unmet need, so a lot of the focus, at least up until now, and in the context of all things government money and spending, it has been really important to focus on the services as well, just because we know there has been, you know, there's a tendency to kind of focus at a system level on physical health over mental health, so it's been really key to make sure, particularly for the serious mental illness side of things and inpatient, we get that right. But certainly kind of post 10-year plan, in thinking about the next stages of these kind of mental health moments and how we actually take the blueprint of a 10-year plan, which as ever will be a plan until it's actually implemented. A key bit of that will need to be that universal support offer. So it's, I think, really important that we don't, because there is a need for clinical specialists, and in some of the kind of commitments that exist around things like support in the community, neighbourhood health, we need to make sure that we've got the right support for the right level of needs. So taking kind of some of our programmes we have already, like early support hubs, we've got 24 of those around the country. We've been doing lots of kind of evidence collecting on what works there, and there's some quite high levels of need who turn up to those early support hubs, and whilst the kind of friends family element is really important, we've wanted to make sure that we don't equate kind of a well-being offer, a light touch well-being offer, with some kind of really robust, credible clinical wraparound support in those kind of facilities. So we're at that point now, I think, of trying to just balance where we need that clinical support element and the services to be right, but totally taking everything Tamsin said. The next phase of that now, I think, is to shift this kind of dialogue to being what, we've thought about mental health training for years, but what does that actually look like in today's current context? And I think the shift, if done right in terms of kind of neighbourhood, community, that's a really good opportunity to get that piece, going. And we're doing lots of work with, third sector, voluntary sector across the board and others to make sure that we're actually kind of designing that in as we go.
Great. And you wanted to come back in, Tamsin?
Yes, I wanted to talk a little bit about some work going on in Exeter led by Abby Russell, which is doing precisely what Duncan and Charlotte were suggesting, in that it's not for children with a diagnosis, could be used for children with a diagnosis of ADHD, but it's about these are the problems, and getting teachers to be able to say that is a problem for this child, let's work on this in a structured way with feedback and how to monitor it. It's called Tools for Schools if anyone's interested. And then the thing about affluence, I'd point you to the HOPE study run by Ruth Gilbert at UCL, which has been using the linkage between the National Pupil Database and hospital episode statistics with outpatients appointments in children to see whether we can model the effectiveness of special educational needs provision. The shorter answer is no, we can't find what's called an instrumental variable, but what we are showing is that there are a group of children who don't have their needs recognised, and it's partly the type of school, but it's also partly the less affluent, and they're getting their special educational needs later. So the narrative about the sharp-elbowed middle classes, actually that's what you have to do to access the system. So we should be thinking about, well, what about those parents who don't have, English as a second language for the family, or the child is looked after, they're more likely to have special educational needs. So how can we make sure that those children get their provision?
Great, thank you. Okay, we've got another question here, and we'll take another one too if anyone wants to raise their hand.
Hi, my name's Anna Workman. I'm in Global Health at the Foreign Office. I wanted to ask a question picking up on what we were talking about this morning. So, you've pointed to the fact there's huge unmet need, but also the kind of challenges of long waiting lists, etc. I mean, it feels as though the gap between demand and supply in this space is not going to be bridged in a very kind of reasonable time frame. What are the kind of innovative models that are being considered to kind of get there more quickly? And, is this a space, picking up on what the speaker was saying this morning, where there needs to be more of a mixed public-private, with the private sort of quality guarantees being given while making sure that there is sort of free services available? Because right now, what I experience as a parent, anecdotally, is just across the board, the waiting list is just so long that people can't resolve problems in a kind of reasonable time frame. So I'm just interested to know what the kind of thoughts are on different ways of getting there, given the scale of the gap and the level of funding.
Thank you. Second one. Oh, sorry, over here, Mr. Sorry.
Hello, I'm Sophie from University of Exeter, and my question follows on really nicely from that, actually, which is a lot of what we've been talking about isn't unique to England, and particularly when we're looking at environmental factors. Are there any examples of best practice globally where they're getting this right, and that sort of interface and connection between education systems and then the health, environment and infrastructure?
Great. Okay, thank you. No, so that's one of the things that's being looked at in this study I'm involved in, and certainly one of the things that's coming out of these early reviews is this issue that everyone here has been talking about in terms of diagnosis as a gatekeeper is much weaker in many of the other countries we're looking at, and there is much more tendency towards that, getting the support in first through the identifying of what the support need is, without those kind of long waits for the diagnosis. But I'll let the panel say more. I saw Duncan waving.
I'm ready.
In just to both of these questions.
So I think it also comes back to the question about bottlenecks, right? So I guess neurodevelopmental conditions is really is what I know more about, more than mental health. And one of the big drivers to get on that wait list to access those services is because the pressures that schools have been under for some time has made them gradually less inclusive places. And so, and that goes through all sorts of things, like to do with teacher training and the competition for what goes into teacher training, to do with the targets that schools have to meet, and the time and the resources that the teachers have, and all of those things mean that the time and space that is needed to make a school more inclusive is often not there. And so that then means that the model we have is that we have a kind of particular model for school. Then if a child or family find that difficult, right, they need to get their diagnosis to access some specialist support so that they can stay in the school or go to an alternative provision. And so in other countries like New Zealand, for instance, they've adopted an inclusion by design for some time, right? So they've done a lot of work to think, how do we make our standard practice as a school just much more inclusive? And that has to go through all sorts of things, including assessments, how schools are rated, how learning is structured, building in some flexibility to the day. And so I think that one of the pieces of low-hanging fruit that we could reach for is to try and make our education settings more inclusive by design, such that to try and minimize the need where we can for someone to have to go and seek additional external support in order to be able to access the school. So I think one of the things that we need to do is to look to places like New Zealand where they've been doing inclusion by design in schools for some time.
Okay. Comment on either of those two questions we've got from Anna around unmet needs and the waiting lists?
Yeah.
Perhaps?
Yeah, so I think, and actually just to pick up on that in terms of international examples, so we are doing a lot to kind of think about best practice, and also both New Zealand and Australia from a mental health perspective, so thinking about where they've had, there's learnings from approaches they've taken around by design, building in mental health support, and actually, again, a different type of national conversation about early intervention and making sure that at the point when someone needs help, whether that is in a crisis space or they just feel the need for support, whether that is friends, family, community, whatever level you are on the kind of spectrum, making sure that actually we're leaning into that and saying it's no good to ignore it, we need to actually address it up front. And that's been a different type of kind of national dialogue that they've actually had. So I do think there's something here about that kind of public conversation around both the support that can be provided, but also where mental health isn't just a health and government-led priority. I think on waiting lists, so again, sort of post 10-year plan is one thing, but post 10-year plan as well, building on that blueprint, I think particularly around things like digitals. We're doing quite a lot with Wellcome Trust and others to think about how we can, what those innovative models actually look like for reducing wait times. There's lots of conversation around sort of waiting well, but also ideally you don't want people waiting, I think, as part of the challenge, right? So it's actually trying to shift that waiting list narrative again into something which is much more about intervening early. So trying to just draw on the best possible advice there, and again, sort of public-private is something that is being considered in the round as well. So.
Great, yeah. If there's anything you can say on the innovation front as well, I don't think that might be something you might...
Yes, well, that's a happy accident, because that's what I was going to
talk
about.
Good, I thought you might.
There's a lot of interesting work coming out of single-session self-directed work from the States. Jessica Snyder. Now, there are fewer services in the States and worse health coverage, but these are youngsters who are recruited anonymously, but they are demonstrating that this one-off session that they work through themselves has quite a sustained impact on their mental health. Obviously, our context is different, and it wouldn't necessarily translate over, but there is interesting work going on at Bath, led by Maria Lodes, trying to work out whether it adapts to our pathways and where it might sit. I also think we could look to innovation in assessment. So there are colleagues of mine that are using computer adaptive testing, which is a bit like when you buy something on Amazon and it says, oh, you like this, you might like that. Well, it does the same thing with questionnaire items. So instead of one for anxiety and one for depression and one there's a whole bank of single questions, and it's like a sort of mental health thermometer. It's been validated for secondary schools, and there is a large multi-academy trust who are using it at the moment. More evaluation needs to be done. There's also an adult version designed for job seekers. So can we measure mental health and give feedback? But then maybe the measure that I was reporting on is a really gold standard, as close as you can get to clinical care. That's available as a self-complete. Could that not be in the pathway? Maybe not for every disorder, maybe not for the milder ones, but that means you don't need an hour or two of a practitioner's time to do the assessment. They spend 15, 20 minutes looking at a complex assessment. Then they can engage with the family without thinking, oh, I've got to ask about this and I've asked about that. They can engage with the young person and their carers about what their issues are, being confident that the ADHD and the autism has been picked up. And then you can triage and direct people to the level in that triangle of services that people actually need to go to. So I think we need to get smarter. We've got lots of access to tools, and we need to try them out and get smarter at the way we do things.
That's a nice positive note as well, in terms of there being some possible solutions there. This may be our last round, so hands up for the last two questions. We'll see how we go. But got one question here.
Hi, I'm going to ask this question because I come from a biomed background, but I'm going to ask a question about money and return on investment, and I hate myself for it.
You share your name as well before you bring us down that path.
I'm Becca. I currently work in MHCLG. There might just be a very simple, we don't know answer to this, but in lots of things we do in government, you kind of need to make your case. Either the cost is so huge that it's terrible and we must do something, or there'll be this great return on investment if we do this thing. So is it the case that we just don't have enough success stories to be able to determine what the return on investment would be if you got the support right? And can you look to the examples you just said in other places where they are getting it right? Or conversely, ideally, all children become adults at some point. They then enter the workforce, et cetera, et cetera. So what's the cost of failing to provide the support? And the bit I will be less embarrassed to ask, it's not just about money, is are there other metrics? If you look at success isn't just GDP, if you ask some people. So are there other metrics of success in terms of happiness or whatever those other kind of indexes are that you could point to that if you fail to get it right, this is going to happen. If you get it right, this would happen.
Okay, great, thank you. And the second one? Oh, there. Let's take three then, given that it's probably our last round. Do you want to go?
Sure, yeah.
Yeah, no, we'll take both.
Oh, God, now I've lost it.
Others, so.
Thank you very much indeed. Sorry, facial recognition kicking in, I hope. Okay, no, it's okay. Okay, I'm Head of Girls' Education at the Foreign Commonwealth and Development Office, and I was going back to this issue of assuming 15% is accurate broadly for the Global South as well as it is for elsewhere, although we may have less evidence and research done there. When pressures bear down on budgets, and for governments in those countries or indeed our own, how do we make the arguments, it goes back to what Becca was saying, I think, in part, for the positive benefits of inclusion, and what is the kind of support that we could share from the UK to help governments in countries where they're struggling with GDP, and we know, forgive me for this term, that the unit cost of supporting a child with all sorts of disabilities is higher, because it often is intersectoral with poverty and all sorts of other issues, than for a child who's easier to access, more part of the sort of critical mass of children that are easier to help. What are the arguments we could share from the UK to persuade them, and indeed our own government possibly, to allocate budget to those children?
Okay, and some overlap with Becca's question there. And one final question there.
Thank you. My name is May Chow. I'm an editor at Nature and a student of public policy. So I have a question about the science. Going right back to the first talk, when you say it's very difficult to find correlations, and the variability is huge, and it's hard to map you know, what neurodivergence versus, you know, brain. Is it a question of data? Like if you had infinite data and infinite data processing capability, would you be able to crack it? And even if you could, would that actually have any impact on the treatment?
Okay, thank you. Great set of final questions. So we've got two there around some of the kind of tangibles of measuring, and particularly great to have an expansion of that conversation to the Global South there, and then probably one which specifically for Duncan in terms of weakness of data. But I think, Tamsin, you wanted to come in on the ROI point.
Yes, absolutely. I don't think we can afford not to intervene. So the prison population has the most enormous prevalence of young people with ADHD. I'm not sure that the autism or other types of neurodiversity have been so measured in so much detail, but ADHD, absolutely. There are also costs in terms of, you know, one of the most expensive ways to look after somebody is to put them in prison. There's also a higher risk of accidents, attendance at A&E, admissions, substance misuse, occupational failure. There haven't been enough cost of illness or cost benefits studies. They're beginning to happen for ADHD, and I'm part of the ADHD review that Charlotte mentioned or had on her slide, which is why I know the data around that one. I think that I'm aware of one or two cost of illness studies around autism. Again, it's huge. So the costs of not supporting these youngsters to cope with school, to develop some life skills, and to then to be able to contribute to society is enormous. And then in terms of building resilience, coming back to our title, there's a famous study in the States where instead of investing in another prison, somebody coming into government invested heavily in violence protection programs, loosely defined, focusing on children and young people, and they reckon that for every $1 they invested, they saved 9. And similarly, some work, I'm linked in with a charity called Place to Be, who offer mental health training and interventions in schools across the UK. And we use the national surveys that I showed you as a kind of quasi-control, because they have really good outcome data. Their follow-up a year later shows that, you know, the scores on the strengths and difficulties questionnaire come down. A year later, they've stayed down. But there's no counterfactual. Maybe that's what would have happened anyway. So we match them up. It's called propensity score matching. We match them up with children in the national survey who have as many of the same characteristics. Probably the benefits in terms of mental health of this counselling, low-level counselling, were there 2 years later. And Pro Bono did an economic evaluation that suggested that for every £1 the school was spending on Place to Be, they were saving £9 on extra resources that would be used to support the children. So there's not a lot. We need more of it. There aren't enough health economists who are doing this work because it's really, really complicated and difficult to do. But it's really important to do because actually, as you say, that's what governments listen to. And I think that maybe goes some way to addressing your question too. I know there is some interesting work in the pipeline on the Global South via data collected by UNICEF that's been analysed that will be coming up about mental health and predictors across, I think, 11 countries.
Okay, thank you. Duncan.
Shall I do this one, the science one? I don't know the answer to your question. Other than there was some really interesting work done by someone like Anna Vignoles, I think, in like economists of education, exploring the overall kind of cost of not meeting needs in school or kids dropping out of school. But it's not my area of expertise. But on the brains, so one of the reasons it's not about amount of data, right? We've got some super enormous data sets now, so tens of thousands of kids. and it's still really hard. And the reason it's hard is because of a sort of fundamental misunderstanding of how the brain works. And the reason that we had that misunderstanding is because the way we would study the brain is take an adult, and then an adult who has a brain injury, like a lesion from a stroke, for instance, and then explore how their brain has changed. And of course, the point about a developing brain is that it's a kind of self-organizing system that's kind of self-organizing and emerging over time. And I suspect that many of the characteristics that we are interested in, like inattention, hyperactivity, are not the result of our bit of brain that isn't working properly. It's something more about the dynamics of the system as a whole, that you cannot boil down to our connection or our bit of brain. So what I think we need is kind of more powerful kind of computational tools and methods, often borrowed from engineering, which we're kind of starting to do now. And I think that is the key to better understanding how this self-organizing system over time can result in something like inattention or hyperactivity. I don't think those things will line up neatly with diagnoses, because as we've all said, that's not how nature works. Will that make any difference to treatment, to intervention and so on? Yeah, maybe, in like a long way down the line. But I think there's a lot of other things that we can do that would be much more immediate, like work out a really good way of doing a good needs-based assessment more rapidly. And so the work that we do in our group, some of it I think is really exactly in that space, and there's some more kind of blue skies work that we do to like try and understand the developing brain that I don't yet know how that will translate to changes on the ground, but we're just doing it because we think it's really interesting.
I think those points on education are perhaps a moment for me to jump into my enhanced chair role.
Yeah.
So there's a huge amount of analysis that's been done to show the return on investment in terms of school exclusion, which is obviously very closely linked to this. So some of that has come through the work that BIPPR has done with the difference. Most recently, I worked on a report where we looked at the what the return would be on investing in speech, language and communication needs on a preventative basis and SEMH, so including mental health conditions. There we found that an additional investment would pay for itself by the end of this Parliament and then generate a return on that. We modelled it in terms of reduction in need for EAHCPs. So there is that, some of that information is out there. I think the mention of New Zealand was interesting. I think that kind of illustrates some of the trickiness of this in the education space, because I think making the case for more inclusive schools in the department can be tricky when the examples are places like New Zealand, which is its educational outcomes are not going in the right direction, and they're doing everything they can to emulate England now. So yeah, sometimes in terms of the educational data that can be trickier. But we do have these examples that really show that some of the investment in support can pay dividends quite quickly. But I think maybe final word should probably go to Charlotte in terms of articulating this from the corridors of Whitehall.
Yeah. I mean, I think obviously the sort of the return on investment question is as you all know, a key one, and we, so at the moment, sort of talking therapies, of our interventions, talking therapies are the ones which are kind of formally scored and OBR scored so that Treasury and others can take into account the economic impact. But one of the things we are looking to try to do is emulate that for things like mental health support teams in schools. Obviously, sort of talking therapies, because of their link to economic growth and work and health and kind of the growth mission agenda are attractive in a Treasury sense, but we are, particularly in the case of children and young people, trying to make the case that if we can grow outcomes data, and obviously this is a kind of, again, partnership thing we need to do across government and also with NHSE and with local systems to make sure that we, as you were saying earlier, Tamsin, bake in outcomes data much more in order to be able to effectively measure and demonstrate kind of impact. I think all of the examples we've talked about today are really important to work through, and I think we post this sort of first year of kind of scene setting on everything. Now we're through sort of spending review, things are set in terms of parameters. I do genuinely think now is the time. It's not like things are kind of written in and out, and I think now is the time to actually bring all of these things together to kind of set that direction moving forward. So I think that's a particularly important kind of message I wanted to land as well, because I think we are just in we're in blueprint world, but there's just so much out there that we now need to consolidate and bring together using the parameters and the funding and everything else that we have, but using it to the best effect. And as we've said consistently, you know, when we do need to do more with less, as is the way across the board everywhere, you've got to be drawing on kind of best practice and doing things together and collaboratively, because I just think that's the only way we can do that, given where we are. So,
thank you.
Helpful.
Okay, great. Well, I mean, one thing that comes to mind as we kind of finish discussion for me is the fact, I think when I first started working in this area back 15 years or so ago, I think often what we were trying to do was very much make the case for why this was an issue that people should care about, you know, getting it up the agenda, building the salience and so on. And I think the character of the discussion we've had today almost does show how we've moved on from that to a discussion that is much more about what do we do now, and increasing kind of glimmers of actually here are some avenues we might pursue. So hopefully we can, some of this expertise that we've got in the room today can really help move things forward on that. So thank you so much for joining us, and thank you for having for such a fantastic panel.